Welcome, everyone. I am Jill Chmielewsky, and I'm joined by Dr. David Rosensweet, Dr. Holly Papanek, and Dr. Lindsey Berkson for a discussion on estriol and Bi-Est. There is a lot of noise in the menopause space, and as a result, we receive a lot of questions from both patients and providers asking why a clinician might choose to use Bi-Est in a woman's HRT regimen versus estradiol alone. So we are going to walk through the science and, of course, talk about the physiology of the body, estrogen receptors, and estriol's role in the body so that you understand why we and so many of our clinician colleagues prefer Bi-Est versus estradiol alone. So without further ado, Dr. Rosensweet, do you want to go ahead and share your slides and we will get started?
One of the questions is what best copies nature? And there's been discussion, and this is an example of a podcast we were recently on in which this controversy came up, and really we got inspired to go further because we definitely have strong opinions about what does copy nature and which way is the proper way to go. And we'd like to address this issue where there's a suggestion to treat with estradiol only rather than with estriol, because the claim is estriol is a hormone of pregnancy only. So we all learned about this through many different vectors, and this is one of the principal ones. It's Dr. Jonathan Wright. He's one of the founders of the bioidentical hormones being prescribed in the United States and the world. And he was working off some information from this doctor when he began. And Holly, in fact, you might even tell us what Dr. Wright was thinking when he was questioned by that patient, why he got into this world of bioidenticals. Would you tell us that story?
Sure. Dr. Wright probably wrote one of the first Bi-Est. I think he initially started with a Tri-Est script. And what he found that we knew at that time that there was E1, E2, and E3. So estrone, estradiol, and estriol. And he was trying to figure out, okay, what components do I use? But in the meantime, all he had was Premarin or horse estrogen. And so one of his patients came to him and said, per his writing in his book, I don't want horse estrogen. How about you get me some human estrogen and figure out what that looks like? So that really kind of started this off. And I suspect he maybe wrote one of the first estrogen prescriptions here in the US, at least from what I can see. And so that kind of unraveled and kind of how to decide each one. So
it was patient generated into the ears of a very wide open, creative doctor. And what Dr. Wright originally discovered was this research done by Dr. Henry Lemon, who's an oncologist at the University of Nebraska. And one of Dr. Lemon's main interests was studying breast cancer. And what he did is he wondered if there was a hormonal relationship to breast cancer. And as I was reviewing Dr. Lemon's work, one of the things that this is a little bit of a diversion, but he was writing in the late 1960s, in which he's reporting cancer of the breast develops in 6% of all white women. And that's the 60s. Now it's 14%. This isn't directly relevant to estradiol and estriol, but I wanted to bring that out, that what's going on here, well, we all have ideas about that. And what he did is he examined the urine of young, healthy women, because you can look at the hormones. And he was using GC mass spec technology, which is very highly technical, and it's really state of the art. And he also examined the urine of women who had breast cancer, and he found some differences. And he found that the estriol content of a young, healthy woman's hormone profile in the urine, that there was more estriol than there was the sum of estrone and estradiol. And he created this math called the estrogen quotient. And what he found the average to be in a young, healthy woman was 1.3. In other words, there was 1.3 times as much on average, of course, there's a range there, than there was the sum of the two most potent estrogens, estrone and estradiol. So young, healthy women have more estriol than they have the sum of estradiol and estrone. So this is not just the hormone of pregnancy. This is present. And then, interestingly enough, women with breast cancer, you often have less estriol, thus an estrogen quotient less than 1. So the average age of young, healthy women, as determined by Dr. Lemon in the 1960s, was 1.3. Well, it turned out that Metametrics Laboratory, some of you may know about this, in the early 2000s, they wanted to start doing 24-hour urines. and they gave me quite a bit of research grant. I asked them, well, let's find out, what are young healthy women? What's their distribution? Really a desire to repeat Dr. Lemon's work. And we interviewed 600 nursing students, 20 to 29, healthy, never been pregnant, regularly menstruating. That was necessary because we had to predict what their mid-luteal phase was. And what did we learn? 100 of those 600 actually had regular periods. Stop and think about that for a moment. Those were the ones that we were able to get samples on. And Dr. Wright was so interested in this that in his laboratory, we ran the studies on them. And it turned out that the average estrogen quotient on these young women is 1.1. This is 40, 50 years after Dr. Lemon discovered it. In other words, the women that we tested, young, healthy women, 20 to 29, they had 1.1 times as much estriol as they had the sum of estrone and estradiol. Why am I lingering on this, emphasizing this, sort of going wild on it? Is because young women have more estriol than they have the sum of estradiol. Estriol is not just a hormone of pregnancy. So we went further with this. Here's some examples of some young women that I had tested because their mother and mother-in-law thought that it would be useful because they were young and healthy to see what does it look like, their hormone profile, so that when we went into menopause, we could compare them to their early life stuff. And just to give you an example, this one patient, she was 30, she was thin, a little bit tired, but relatively healthy, never been pregnant. Her estrogen quotient was 2.8. In other words, she had 2.8 times as much estriol as she had the sum of estrone and estradiol. And here's another one. This woman was young, healthy, very vigorous, and with an hourglass figure, and she had an estrogen quotient of 1.1, just the very average that we had. Interestingly enough, we had I had a woman patient who had breast cancer, and she knew that her daughter had some of the risk factors because her daughter was obviously estrogen dominant with a constant breast pain. Think of that, large breast, constant breast pain, 27 years old. And it turned out she happened to have less estriol than she had the sum of estrone and estradiol, 0.8. I'm not saying that this was going to give her breast cancer, but the other thing about her is her hormone levels were so much higher, so much beyond what the common reference range is for young women. In fact, if we place these young women in a spectrum of what's minimum amount of estrogen, what's a more abundant amount, this woman fell into beyond the range is how much estrogen she had to begin with. Back to Dr. Wright. In the early 1980s, he uncovers Dr. Lemon's research, and he suggests that we should copy nature, and that we treat women in menopause, and this is what Holly was giving us the history of, but that we try and replicate what nature does. We try and replicate the pattern that nature has set off in young, healthy women. And nature says that there should be more estriol than there is the sum of estrone and estradiol. And we confirm this by 24-hour urine hormone testing. And he developed Bi-Est, in which it's an estrogen topically applied that has the combination of estriol and estradiol in it, both hormones, estriol plus estradiol. This is what young women have. And he started off with a percentage of 80% estriol and 20% estradiol, because what he found was in many instances, if not most instances, this would produce a hormone profile that copied nature. In other words, looked like these nursing students that we got to interview personally. Well, along comes this Dr. Devaki Berkson. What do we know about her?
Well,
let me give you a full view of Dr. Berkson, because she's here in living technicolor. What an honor to know you after all the many, many years we've known each other.
I had breast cancer 33 years ago, secondary to my mother being given one of the most powerful endocrine disrupting chemicals, diethylstilbestrol, nicknamed DES. Many of the daughters got breast cancer, so much so they now get reimbursed legally with lots of money. I helped that happen, but I didn't get in on that money. And you were one of my doctors when I had breast cancer. And my whole life, Jonathan Wright was a mentor of mine, and I've been writing books on hormones. And based on my first book on endocrine disruption, which is such a story because my life was ruined and saved by hormones and ruined by endocrine disruption and saved by balanced hormones, I got invited to be a distinguished hormone scholar at an estrogen think tank called the Center for Bioenvironmental Research at Tulane, where I got to work with Yanaki. So there's Yanaki, and there's in the 1980s, Elwood Jensen discovered the first estrogen receptor, and Yanaki discovered the second. And what's really important is that estriol mainly signals the second estrogen receptor that Yanaki, that I got to hang out with at Tulane, also discovered. So we know that there are three major estrogens: estrone, estradiol, and estriol. Estrone has this little funny, quirky carboxyl group, a double bonded oxygen, which makes it hold on to metals. And we know that cadmium and lead are instigators of breast cancer. And so we no longer use Tri-est because of that quirky little aspect of estrone. So we're looking at the question, does a woman get optimal HRT with estradiol added to estriol, or should she just do it to estradiol itself? So going back, let's just take a look at how hormones work. Hormones look for a target tissue that has satellite dishes on them called receptors. And the ligand can be any hormone. In this case, we're talking about estradiol or estriol, but the ligand can be testosterone, progesterone, insulin, thyroid, etc. But the hormone parks into the parking space, binds to the receptor, and delivers its signal to hopefully keep us young and vital, just like all of us on the air today. There are two major estrogen receptors, and when I say that, I'm talking about this receptor right here. So there's two major receptors: ER alpha, that was discovered in the 1980s by Elwood Jensen, and ER beta, that was discovered by Yanaki in 1996. And when ER alpha is signaled, it promotes mainly, not totally, but mainly growth. Dr. Rosensweet likes to refer to it as proliferation, growth, because we need growth and we need controlled growth. And the balance between those two functions helps the health of local tissues. ER beta, the second estrogen receptor discovered in the 1990s by Yanaki, mostly signals that controlled growth, or as David likes to say, anti-proliferation. And what is cancer but growth out of control? So proliferation or anti-proliferation needs balance between those ligands or hormones that signal growth and controlled growth, or proliferation, another term for growth, and anti-proliferation, another term for controlled growth. This is so much the case that when Yanaki first presented estrogen receptor beta on the cover of his seminal paper, he had the justice scales of balance, because he said it's the balance between growth and controlled growth that protects tissues from your brain to your breast to your prostate all over the body. So there's three major estrogens, as I said before, and estrone mainly signals growth. Estradiol signals 50% growth, 50% controlled growth. That's why some people say, why not just give estradiol? It does both actions. But then we've got estriol, 1/8 as potent as estradiol. But what the heck? It mostly signals controlled growth. It is the major signaler estrogen of the body of ER beta. So estrogens bind to receptors, either ER alpha or ER beta. Estriol mostly signals ER beta, and Yanaki has clearly been pumping out many papers showing that whatever signals this second receptor is an anti-cancer agent, an anti-inflammatory agent, and he has multiple papers showing that whatever signals ER beta, like estriol, can protect against cancers, can protect mood dysregulation. Whatever signals ER beta is very protective. So hormone health is about receptor functionality, ER alpha growth, ER beta controlled growth. So let's do a deep dive on ER beta, that is a huge protector and largely signaled by by estriol. Cancer docs and cancer researchers both demonstrate that estriol protects against multiple cancers. You've just heard about Dr. Lemon. Dr. Yanaki Gustafsson has published many papers showing that whatever signals ER beta should be considered adjunctive care in many tumor cell lines. And he has papers out showing that whatever signals ER beta in animal and cell models is effective against ovarian cancer, breast cancer, glioblastoma, one of the nastiest cancers, and there's even clinical trials right now using it to take a look at treatment of schizophrenia and neurodegenerative diseases, because whatever signals ER beta is calming, is anti-inflammatory, and is controlled growth. There is a huge body of literature on this. So I find it deep in the ghost of my ovaries upsetting that the experts online who are presently, and I think that they believe what they're saying, online, many people are parroting that they have done deep dives into the literature and find no benefit on estriol. And I question whether they've really looked at the science. So let's take a look at this. This is called ER beta and breast cancer survival, and it's ER beta signals. So whatever signals ER beta, which estriol parks on into that receptor or parking space and produces ER beta signals, is very protective in breast cancer patients. Here they looked at 20 studies that looking at a large number of breast cancer patients, and they showed that ER beta status was very important. If you had good ER beta signaling, you lived longer. With disease-free time, that you lived longer. This is a big deal. In ovarian cancer, Yanaki has published several papers. We know it's one of the deadliest of all gynecologic cancers. It develops chemo resistance, and there's emerging evidence that ovarian cancer cells express ER beta that functions as a tumor suppressor. However, the clinical utility of ER beta agonists remains elusive, and he talks about the emotionality of clinicians to look at something other than estradiol. They basically conclude our findings demonstrate that ER beta agonists, estriol is an agonist. It signals, that's what it means, signals the ER beta receptor, can modulate several tumor suppressive pathways. It helps down-regulate the growth of ovarian cancer cell lines. What a novel thought. And on top of that, there are many papers that take a look, well, where do we have ER beta receptors, or these satellite dishes in what's called target tissue? We also have it in our brain, especially where mood is regulated. So in the brain, there are many. Here's an oxytocin receptor, would be this light gray, purple color. ER beta is expressed almost on exactly on top of each other. Oxytocin receptors are right on top of ER beta receptors, and that's why there's clinical research right now looking at giving whatever can park into that ER beta parking spot, like estriol, for the treatment of schizophrenia, because estriol acts as an anxiety reducer, a mood reducer. It acts a little bit like progesterone in that it is a calming signaling hormone. Who wouldn't want that added to their hormone? We also know that ER beta heals the gut. The gut, for some crazy reason, which is the separation between the outside world with the inside of us, is only one cell thick with columnar enterocytes back to back. But they open after a meal to let the good stuff into the bloodstream, and then enterocytes are supposed to close. They open and close and open and close. And what closes them up are sticky adhesive proteins. Well, what upregulates those adhesive proteins? But estriol. Now, estradiol upregulates some, but estriol regulates the largest class, the occludins. That's why people are more prone to microscopic colitis and different gut issues as they get older, because they have less hormones. And when the gut opens, it can't reclose. So ER beta is incredibly helpful for healing leaky gut, preventing leaky gut. It's a major gut protector. I want that as part of my hormone replacement. I don't know about you. Birth control pills are the one thing that's available OTC since the summer of 2023. And we do know that every single study that measures if you're on birth control pills, what's your vulnerability of breast cancer, shows all studies show a positive link. When you're on birth control pills, you have an uptick of risk of breast cancer, and even so many years after you go off. One of the reasons is that birth control pills block ER beta, because ER beta is a cancer protector. I think that's a really big understanding. Now, there's other reasons why birth control pills are leading the pack of increasing vulnerability to breast cancer, but we don't have time to go into that. But we all now know that many diseases have an epicenter of inflammation run amok. And estriol is anti-inflammatory. It reduces pro-inflammatory cytokines. Those are the signalers that cause inflammation or tamp down inflammation. So estriol is helpful in so many issues and diseases that have a pro-inflammatory content. And estriol signals ER beta, which stops breast cancer. This article is called Estrogen Receptor Beta Inhibits Breast Cancer Cells Migration and Invasion. This is quite extraordinary. And what's everybody's concern? Everybody's concern is estrogen going to give me breast cancer? And estriol delivers the anti-breast cancer signals to ER beta. So ER beta, this is some more information. It's important to have a balance between both, but endocrine disruptors can perturb the balance. So if we're all exposed in our air, food, and water to endocrine disrupting chemicals, we want estriol on board so that our ER beta doesn't become dysfunctional. There are multiple studies on ER beta being protective against colorectal cancer. Most of us know that when women are younger, we have a lower risk of colorectal cancer all throughout the colon and in the rectum. As we get older, our risk elevates because our hormones lower. But what's the estrogen that really protects the gut wall? Estriol, because it signals ER beta, which the docking or satellite dish or receptors completely line from the north to the south and your entire digestive tract. And the biggest deal is Yanaki has multiple papers out on glioblastoma, the nastiest, almost death sentence of a cancer, a brain cancer. And he's been able to show that whatever signals ER beta in a cell and animal model of this glioblastoma acts as a tumor suppressor function in gliomas. It's very effective in gliomas. And there's not much they can do for glioblastoma patients. So why wouldn't you consider giving estriol? And there's multiple papers on that, multiple papers on the role of estriol signaling estrogen receptor beta and being helpful even in some of the nastiest cancer lines. So the conclusions of this article, which is the update on the therapeutic significance of estrogen receptor beta in malignant gliomas, is that it could be a potential drug. Whatever signals ER beta, which is estriol, can help prevent and maybe even help treat one of the nastiest cancers we know. So if ER beta agonists, that means whatever signals that second estrogen receptor found 10 years after the first one, and now we know it's a big deal because it maintains balance between tissues, they help even the worst cancers like glioblastoma, ovarian cancer, breast cancer. Why would you not want this in your HRT? And in the 20th birthday, which is 2016, of his discovery of ER beta, Yanaki Gustafsson was bemoaning in this article, which I promised everybody after this talk I would send to them the whole article because you couldn't get it in PubMed online. It's kind of like Rodney Dangerfield. Estriol and ER beta ain't getting no respect. And he said, is it because clinicians are so emotional that they're Velcroed to estradiol? This is a situation that's very upsetting because there's no acceptance of ER beta when we know it's so protective against inflammation and against multiple cancer cell lines, including what a lot of women are worried about, breast cancer. So I just put some of that information here about the importance of all that. And this is just the tip of the iceberg of estriol and ER beta protection. And there are multiple papers on agonists or what signals ER beta, and estriol is one of the major physiologic signalers in both men and women of ER beta. This is just the tip of the literature. So if experts are out there saying they have done a deep dive in these iceberg-rich waters and they have found no science to show benefits of estriol, then I don't think that they're looking in PubMed or American literature, or perhaps, I don't know, are they reading comic books? I do not know, but there is a tremendous body of literature on the protection and benefit of estriol signaling ER beta, and I want that. So I had breast cancer 33 years ago. David was one of my doctors, and now I've been on bioidentical hormone replacement, including estriol, for almost 30 years. And I'm going to be 76 in about a month and a half. So blessings, everybody.
Thank you so much. And thanks for plunging that deep into that topic.
Thank you for helping me. 33 years ago, I maybe wouldn't be here today. It's so interesting to connect the dots of all our lives. So blessings to you and to all of you present here.
Wow.
Yeah,
Remarkable.
I know.
And I'm so glad that you did the deep dive.
And how many oncologists still tell breast cancer patients not to eat soy because it's estrogenic, but it basically signals ER beta. It's one of the best foods for breast cancer patients. And if you read the literature now, there's no debate. And there's even studies that show that if you got breast cancer and you didn't eat soy young in life, like a lot of Asian women do, if you consume soy several times a week, you have a statistically significant decreased risk of recurrence. So we don't want women to miss out on that.
So I'd like to recap just a little bit in summary form of what Dr. Berkson was saying here, and not to go through the history again, but to say that ER beta inspires deproliferation in the last phases of every woman's cycle, if there's no impregnation, if there's no implantation. And ER alpha's primary stimulant is E2. I'm just repeating what Dr. Berkson said. And ER beta's primary stimulant, inspirer, is E3. Young women who are cycling often feel the proliferation, the development of brand new breast glandular cells as their breasts become fuller over the course of their cycle. And they also feel deproliferation, as if they do not get pregnant, these cells disappear by a process called apoptosis. I love that name, the disappearance. The traditional depiction of the menstrual curves goes like this. This is the hormone levels of estrogen and progesterone. We're leaving out testosterone here. But this is not an accurate one. Actually, what it looks like on a quantity issue is that the progesterone numbers are very high, and during the first phase of the, first 12 to 14 days of a cycle, there's there's proliferation of a uterine lining in preparation of a possible impregnation. And in the second phase, it's the deproliferative phase of this cycle. Again, this is under the influence and inspiration of ER alpha. This is primarily under the influence of ER beta, deproliferation, proliferation, estradiol being the chief proliferation inspirer, and ER beta being inspired by estriol. Well, Holly, would you talk to us about Dr. Altman?
Sure. Dr. Alan Altman published an editorial. It was back in 2007 in Reproduction and Menopause. He's a gynecologist and an assistant professor at Harvard. And one of his topics, although he covered a lot of things, it's a nice article to read. Some of them have been proven correct. Some are a little bit outdated here, but he specifically focused on, I'm going to talk real quick about mammary epithelial proliferation occurs with each cycle. We've known that, right? This has been going on for decades. This has been information we're aware of. You can see it in histology or even down all the way down to the cell types. But we know that E1 and E2 are our most potent estrogens. They're anabolic. Even in some of the literature, they're called trophic growth hormones even. They promote growth, right? And we want that, right? This is the beginning or the proliferative portion of every woman's cycle each month. We're hoping that that uterine lining grows. We're hoping that their cells are dividing. We're hoping we're getting more cells and that we have a robust, thick endometrium such that when that fertilized egg comes down, it has a nice place to rest. We're also seeing it within the breast tissue though, too. If that fertilized egg comes down and we start to get implantation, that breast needs to be dividing. It needs to be ramping up. We need cellular mitosis, cellular growth. The term we use in medicine is hyperplasia. So just kind of that extra added cells and extra tissue to support this baby and lactation, which may be needed. And this occurs with every single cycle. And you don't have to look at the cells and the histology on this. You can ask any woman, right? They know like when those tissues are really starting to get robust. Women feel full. They're not going to tell you I'm having hyperplasia, but that's exactly what's happening. There's growth. It can be uncomfortable. It's stimulatory. It's trophic, even anabolic, they call it. Interesting, in the Cancer Journal in 2020, they actually said in mammography, they can tell when it's a mammography picture of a follicular phase where things are really growing and we're starting to get a lot of proliferation versus kind of more of the luteal phase and kind of the appearance. It'll be interesting to see with some of the new QT technology where they can really hone it down to the cellular level to see kind of what some of that hyperplasia and what that proliferation looks. But kind of in summary with Dr. Altman, again, a robust article about a lot of going. His bottom line is do not promote proliferation. Don't push for hyperplasia or excess cells and extra turnover and extra tissue in a menopausal woman. That's kind of a tricky time. It's a vulnerable time for that mitosis and such, whether it be toxins or what have you. So we have to be careful in terms of really adding to that.
Fun. Let's look at how much estrogen potency is really needed to cause proliferation, beginning with the two most potent estrogens, estradiol and estrone. Young women at a minimum will likely cycle if they have sufficient estrogen potency to produce an endometrial lining. Simultaneously, each and every cycle, as Holly was saying, they're beginning preparation for possible lactation. Amazing. Every cycle by breast glandular cell proliferation. Strategy in treating most women in menopause, not all, there are exceptions, keep their E2 plus E1 dosages below a treatment level that does not produce proliferation of breast glandular cells. I'd like to repeat that. For most menopausal women, and there definitely are exceptions though, we want to keep their potency, their estradiol and estrone, below a level so that we do not get proliferation of breast glandular cells. And there is an important exception. When there's cognitive issues involved, some women need really robust levels of estrogen. Just to give you an example of how it looks on a test report, and this is a 24-hour urine hormone test, and we're comparing the levels in a menopausal woman for a 20 to 29-year-old female. Because this is when a woman's hormone levels are richest, so we want to compare them to that. And when we circle in on the two most potent estrogens, estradiol and estrone, and we look at that green zone there, what's the minimum? What does it take to menstruate and even begin lactation? Well, a woman must have at least 4.6 micrograms of 24 hours excretion of estradiol and 9.2 micrograms per 24 hours of estrone. This is where the potency is. And when you add those up, that's 13.8 micrograms total of the potent estrogens. Well, that's the minimal a young woman needs to menstruate and thus produce proliferation in her breasts as well. That occurs every single cycle. We're looking at a reference range of a 20 to 29-year-old. When we look at a different reference range, and this one is extrapolated from the medical literature, when we define how much potency should we have for treating a woman in menopause, notice that what we recommend is that a woman most women not get above 14 micrograms per 24 hours. That's the upper limit suggested for treating a woman in menopause. We don't want her to proliferate. And when she goes above 14 micrograms per 24 hours, she could proliferate breast glandular tissue. Again, there are exceptions. And that exception is in the yellow zone. Now, taking a deep breath, flurry of information. Regarding the commentary, treat with estradiol alone, the body will handle it in such a way that there will result in the appropriate amount of estriol. I have heard this over and over again from many providers, and I wonder, where are they getting this information? I explored this because I heard this from a trusted colleague in 2009. And he said to me, he's been treating women for years in menopause. He said, why, you don't need to give women Bi-Est, which I had been doing for 15 years. You can just give them estradiol and they'll do fine. They'll produce all the estriol that a young woman will produce. So, adventurer that I was, I decided to switch all of my patients, all of whom were on Bi-Est, to estradiol to see if what he was saying was true. And the following is the universal typical results of 24-hour urine hormone testing done on 5 of these patients. I say universal because this was 100% of what I discovered. So here's an example of a 24-hour urine hormone report. This is when this patient was on pure estradiol. I had switched her out. And look at her estrogen quotient, 0.5. This is when we switched her back to Bi-Est. Now her estrogen quotient is 5.6. She's got 5.6 times as much estriol as she's got the sum of estrone and estradiol. Here's another patient, and another patient, and another patient. and another patient. And I'm just going to give this to you in summary so I don't bedazzle you with a lot of numbers here. But look at DB. There she is, 0.5 on estradiol. That's less estriol. And there she is back on Bi-Est, 5.6.
So, David, what you're saying is we are hearing from some experts online that you only need estradiol because the body will convert to estriol, so you'll have enough. But you found that is not the case, repeatedly not the case.
Precisely.
Right?
I'm glad you repeated that one because this is a very important concept we want people to get. Here's a second patient. When I put her on estradiol, her estrogen quotient dropped to estriol levels that were way different than a young, healthy woman, 0.2. Remember, the reference point that Dr. Lemon found was on the average 1.3. What we found was 1.1. This woman's down to 0.2. We could put her back on Bi-Est and she's up to 2.7. Here's a third patient. When we switched her over to estradiol, she's 0.4. Well, like Dr. Berkson was saying to us, we want estriol. We want to copy nature. We want a rich amount of estriol. And here, these women are falling below. In fact, they're falling into levels that when Dr. Lemon did his original research, breast cancer was more prevalent, 0.4. When we put her back on Bi-Est, she's up to 1.3. Here's another patient, dropped to 0.1. These are the levels that were found in breast cancer. I'm not saying this is causing breast cancer, but it was found in women with breast cancer. When we put her back on Bi-Est, she goes up to 2.5 times as much estriol as the sum of estrone and estradiol. And here it is again, at which point, when I started seeing the results, I leaped back into treating women with Bi-Est and have never looked back. Here's some examples of what happens with the patch, for example. Patches are very popular. Well, what's happening with the patches? This woman had 0.4 times as much estriol. She had a quotient of 0.4. This is on the patch. Here's another woman on the Bi-Bel patch, is 0.1 patch. We did the 24-hour urine hormone test. Her ratio is 0.7. Again, not nature. This does not replicate the amount of estriol that's in every young, healthy woman. No.
So healthy women do not necessarily convert estradiol to the amount of estriol that's anti-inflammatory, anti-cancer, anti-anxiety, and protective levels. So that's what we hear online, but it's not true. Right.
I never found it to be so. I found the opposite to be true.
Right.
In other words, when you give a woman estradiol, she does not produce through the metabolism of the estradiol the amount of estriol that nature has given us as a template. So, in summary, estradiol alone did not convert to estriol levels that represented the pattern of young, healthy, regularly menstruating mid-luteal women. And the moral of the story is young women have more estriol than they have the sum of estradiol and estrone. And women with breast cancer have less estriol than the sum of estradiol and estrone. Why am I repeating this? Oh my God, I hope you're all holding up to the repeating of it. But we really want to counter what's going on out there in the world of what's going on chatter in social media. We're really concerned about this, as you might be able to tell. A few of us on this call, as in all of us on this call, feel very passionate about what we found about this subject of Bi-Est versus estradiol. And again, as Debbie pointed out so clearly, E3, estriol, inspires ER beta receptor for deproliferation, and treating with estradiol will not result in natural levels of E3.
I wonder too, some of the misinformation comes from estriol within the plasma itself. It can be so fleeting. It doesn't last very long. And when you check those levels, they often appear on the lower side just because although there's a robust amount, it's utilized very quickly. And so I wonder if they're seeing lower levels, so they just think it's unimportant. I'm not sure exactly where this came from or why it was demonized so terribly. But in the 24-hour urine, it's clear as can be, and these studies certainly show. So I don't know, where did that originally come from, that it was an unimportant, or largely speaking, just a quote, pregnancy hormone? I'm not sure.
I think you're just naming one. It's present in such minuscule amounts in the blood, it comes in and it leaves so quickly that it's tough to pick up on an individual blood test. But Jill, it's a real bottom line question. I think part of the issue we can thank the Women's Health Initiative for. I want to tell you that story. I mean, I grew up in medicine where there were generalists. And then lo and behold, people start specializing, and you get neurology and immunology and obstetric gynecology and knee surgeons and ear surgeons and on and on and on. There was a reason for that. The body of knowledge in medicine had gotten so great, better to pick a lane and really focus in on that lane so you can get great at it. This did not happen in hormone medicine at all. It's still the Wild West. And a lot of commentators that are out there and the dark social media, they've never specialized in treating women in menopause or treating men in andropause. They're part of broad-based practices, and they haven't taken on what is required to really understand hormones in a woman's body that you're treating. You know, we've done split specimen studies. We've compared all the different testing, blood, plus this is for women you're treating, plus the 5 different urine methods that are out there, the 5 different laboratories that are doing this. And over again, we can see that it's only the 24-hour urine hormone test, in my strong opinion, hey, I've got opinions, that really reflects what's going on in an individual woman that you are treating. And a lot of people don't venture into that because I showed you these bars, that one slide that had 5 bars on it. When you look at a 24-hour urine hormone test that comes out of Meridian Valley Lab or Ryan Laboratory, it's staggering. There's so many analytes. When I first encountered my first one, I went, oh, this is like a whole new education. And I think one of the reasons it's avoided is the mere complexity when you really dive deep into the weeds and really explore what's actually going on in one of these tests. So people who are not specializing it, they don't necessarily embrace the whole world of answering the question, what is the proper testing? What reflects best what's going on in a woman who you are treating? And I think that's a couple answers. And it didn't happen in these other specialties. When people started to specialize, they started refining the knowledge base of each one of these specialties, and they're very excellent. And there's a core body of knowledge in neurology, for example, or in gynecological surgery. And there might be some discussions at the periphery, but because of the Women's Health Initiative, I assert, it scared everyone away, and there is no specialty. And there's very few specialists. I know a lot of folks in this field, and I hardly know anyone who's taken it on as this is what I'm going to specialize in. And these are hormones. These are the most powerful biochemicals in our body. There's a big body of knowledge, and it really runs deep when you start really exploring it in detail, as we're doing.
You know, hormones are the only molecules that can speak to genes. The only molecules in the body that can really speak to your archival information from your parents, your grandparents, your great-grandparents. Vitamin D is so infamous because it's a vitamin, but it's also a hormone. And yet, hormones that can speak to genes, just as what you just said, David, the most powerful signaling molecules in the body, and docs haven't been trained in it. So when patients ask their docs about it, they're apt to get a misleading answer, and a lot of confusion occurs. But I don't know why estriol has been demonized. Yanaki, who discovered ER beta, was writing on the 20th birthday. Why is this? It must be so emotional that you don't want to go beyond estradiol. Look at all the benefits that whatever signals ER beta, which estriol is a major signaler of the anti-inflammatory, anti-cancer receptor, gives the body. And why wouldn't you want that added to your HRT?
Dr. Berkson, you had that slide about with brain health, right? And the brain signals. What a lot of what I sort of hear from people is that they don't believe there are ER beta receptors in the brain. And that's where estradiol only is needed in the brain. So this is where all of these little, all of these pieces of learning that you've presented are so important, because I think people get really tied to estradiol alone. That signals brain health. I've heard patients say, my doctor won't give it to me because it will not protect my brain. It will not protect my bones, the blood vessels, all of the things. So it's just
your
so
blood vessels are lined completely with ER beta. The
Yeah.
endothelium of all blood vessels
Yes.
is just lined with ER beta.
Yes.
It's crazy, but it's
Yeah.
ignorance. It's really ignorance. And human beings tend to, I can say this till the cows come home,
Yeah.
be down on what they're not up on. But why estriol is demonized, that's such a great question. I have no idea, but that demonization is wrong.
And you may have heard from us, from what we've been saying here, that we are proponents of Bi-Est. We think it's very important that women be treated with Bi-Est. We think it's very important that men and women get treated with hormone replenishment, and that we choose Bi-Est, and that estradiol does not produce the estriol that some people believe it does. So if you think we're fans of Bi-Est, we've made our case. Anyone else here have anything they'd like to add in completion as we say hello to all you out there in the hormone verse that are going to be looking at this, hopefully a lot, and to the providers. And to the providers that we feel we have a very strong opinion that what you're promoting out there is not the healthiest thing for women. And that's why we are on this, being so passionate about it.
Thank you for all being such healthy and bright beings.
Thank you. That was wonderful. That was wonderful. So on behalf of all of us, we want to thank everybody for watching and listening, and please share this with those that you love, your providers. We're making this public for everyone so that everybody can have access to this. So we're so grateful to all of you for being here and for sharing your expertise. Thank you.
Thank you.
Okay.